So this Insta lecture session would be on pediatric renal tumors. That means renal tumors, kidney tumors which we see in childhood. And initially I would give you a brief overview about the kidney tumors which we typically see in childhood, and then I would particularly emphasize on a specific kidney tumor of childhood, that is Wilms tumor. Wilms tumor is the most common kidney cancer seen in childhood. But before going into the details of Wilms tumor, I would like to focus on the other tumors which you need to know in brief, which are seen in childhood. The second most common kidney cancer which is seen in childhood after Wilms tumor is CCS of kidney, clear cell sarcoma of kidney. Be careful, the name is clear cell sarcoma of kidney, not clear cell carcinoma of kidney. Clear cell carcinoma of the kidney is the most common kidney cancer which we see in adults, but this one is clear cell sarcoma of kidney, which is typically seen in childhood, and it is also known as bone metastasizing kidney tumor of childhood, because this clear cell sarcoma of kidney has a tendency for bone metastasis, and it has also has a recurrence and relapse, and that's why their prognosis is not as good as Wilms tumor. Other than this, the third important kidney tumor which we see in childhood is rhabdoid tumor of kidney. A rhabdoid tumor of kidney is very important because it has a very high mortality rate, often within 1 year of their diagnosis, and they are typically seen in the first 2 years of life, and at the time of presentation they has already spread their tentacles in the many places. They have metastasizes to many places in the body, like it could be in the liver, it could be in the lung, in the lymph node. And other than these three, the top three which I mentioned, Wilms tumor, the second one is clear cell sarcoma of kidney, and third one is rhabdoid tumor of kidney. Other important kidney tumors which can be seen in childhood are XP11.2 translocation associated renal cell carcinoma. It's a variant of renal cell carcinoma which carries a specific genetic abnormality, XP11.2 translocation. Other one is congenital mesoplastic nephroma, and the last one which we like to mention is medullary carcinoma of kidney. Now, medullary carcinoma of kidney is important because they are usually seen in association with sickle cell disease. Mostly these are seen in the adolescents, and they always have some history of having sickle cell disorders. Medullary carcinoma is also kind of aggressive cancer. But if we leave all these tumors which I told, they are far less common compared to Wilms tumor. Wilms tumor is the most common kidney cancer which is seen in childhood, comprising 90 to 95%, and majority of them, 2/3 of them, 60 to 70% of them, they are seen usually in less than 5 years of age group, typically 2 to 5 years of age group, and most of them, 90 to 95%, will be definitely seen in the less than 10 years of age group. So if you are getting a kidney cancer in a less than 15 years old age in a child, in a children, you should think first about Wilms tumor. Now, Wilms tumor typically present within a young kid with an abdominal mass, and other than that, there might not be any features or symptom. Rarely, uncommonly, there could be presentation with intestinal obstruction or hematuria, or metastasis could be seen. That is, they typically present with one particular organ. They have a predilection for metastasis, that is lung metastasis. But in majority of them, as I mentioned, the presentation would be with an abdominal mass in the abdomen. And if you get an abdominal mass in the abdomen in a young kid, you should think about other few tumors also, like neuroblastoma, which arises typically from adrenal medulla. So it can also present with abdominal mass. You can also think about hepatoblastoma, which is a childhood tumor arising from the liver. It can also present with abdominal mass. So all these tumors you need to keep in your list of differential diagnosis. Not only those tumors which I mentioned about arising from the kidney, but also these tumors which can present with abdominal mass. The next very important concept about Wilms tumor is their association with some particular syndromes, congenital syndromes. And these congenital syndromes, they carry a higher risk of developing Wilms tumor in the kidney. And particularly, I would like to mention about 5 important syndromes which are associated with high risk of developing Wilms tumor. And those 5 syndromes are WAGR syndrome, W stands for Wilms tumor, A for aniridia, which is absent iris, G for genital malformation, and R for mental retardation. WAGR. And this syndrome patient, they carries roughly 50% risk of developing the Wilms tumor. The second important syndrome is, I would like to mention, is Dennis-Drass syndrome, and sometimes only called Drass syndrome. And this syndrome is important because this syndrome usually present with gonadal dysgenesis, and they can have a early onset nephrotic syndrome, infantile nephrotic syndrome, typically developing after 3 months, and in kidney they show diffuse mesangial sclerosis, and this pathology is seen. And a very important fact about this Drass syndrome is this, that about 90% or more than 90% cases, almost, that means a majority of them, they would develop Wilms tumor. The third important syndrome after the WAGR syndrome and Dennis-Drass syndrome I would like to mention is Beckwith-Weidman syndrome. Beckwith-Weidman syndrome is a syndrome which is associated with organomegaly. There would be a macroglossia, and they also have adrenal cytomegaly. That means if you do a biopsy of their adrenal cortex, the cells would be bigger in size, and they have hemihypertrophy also. So this syndrome also carries a higher risk of developing Wilms tumor. And the fourth and fifth syndrome, which I like to mention, which carries a higher risk of Wilms tumor, are Perlman syndrome and Sotos syndrome. And both these syndromes are usually, they're associated with organomegaly and or gigantism, I would say. They're gigantism. That means they usually grow very fast, and they're quite big in the size when they're young or in their childhood phase. So these 5 syndromes which I mentioned, you need to know about them. The 5 syndromes are WAGR syndrome, Wilms tumor, aniridia, genital malformation, mental retardation syndrome. Second is Dennis-Drass or Drass syndrome. Third, I mentioned about Beckwith-Weidman syndrome. Fourth is Sotos syndrome, and fifth is Perlman syndrome. And these 5 syndromes, they carry a risk of developing Wilms tumor. The next point that I would like to mention about Wilms tumor is that definitely their diagnosis is usually made with the histopathology confirmation by the biopsy. And in histopathology, what we typically get a feature of triphasic tumor. So these tumors, you can see there are 3 kind of cells. They are made with 3 kind of cells. There are 3 kind of components are there. That's why it's called triphasic. And those kind of 3 components are blastomal component, mesenchymal stromal component, and epithelial component. The blastomal component are typically those primitive cells. They look very bluish, and these tightly packed sheets of bluish cells you can see in many areas of the tumor, which you can easily identify if you look at a biopsy image of Wilms tumor. The second component, second type of cells we usually see is epithelial cells, and they typically try to form some kind of abortive glomeruli or abortive tubules. And third kind of component you usually see is mesenchymal stromal component, which usually you see the spindle cells, and sometimes you can see some heterologous elements like skeletal muscle. So this is a very important concept, that this tumor has 3 phases, triphasic. And if you think about Wilms tumor, this tumor basically tried to recapitulate, they say, the various stages of nephrogenesis. It's like looking like your own album, how you used to look at 6 months, how you used to look at 9 months, how you used to look at 12 months, how you used to look at 2 years. Similarly, if you look at various areas of the Wilms tumor, you can see that how kidney used to look like at 6 months, how it used to look like 9 months. This kind of various stages of nephrogenesis, they try to recapitulate in the various areas of the tumor in the biopsy. And a very important feature that the histopathology dictates the prognosis, particularly the presence of anaplasia, which is seen in roughly 5% cases with nuclear pleomorphism, high mitosis, nuclear hyperchromasia. These features of anaplasia, if they are there, then this actually carries an unfavorable prognosis. And definitely after this, and they can also sometimes present with metastasis in the lungs, which I already mentioned. And another concept that I would like to say here, that sometimes they can have a putative precursor lesions, that means precursor lesions which are made with the primitive cells, which can be seen in these tumors. And if their presence, these are called mesonephric rest. And if the mesonephric rest you can see in the biopsy, then you should look do a serial monitoring for the other kidney, because other kidney has a higher risk of developing Wilms tumor. The other things I will be discussing in the coming lecture. Thank you very much.